So adhesive capsulitis is a condition which is difficult to define, difficult to treat, and even difficult to explain. And I'm paraphrasing from Dr. Codman from an article published in 1934. And ironically, the situation hasn't really changed much. It's still a difficult thing for us to fully treat well and really understand. And the most effective treatment is still debatable on that. We know with adhesive capsulitis that there is a painful progressive loss of motion. There's some sort of pathologic trigger that starts a process of synovial pathology and capsular fibrosis in motion. We don't exactly know what the trigger is. There's some speculation that it may be an autoimmune condition. Anyways, because of the capsular fibrosis, there's contracture in the capsule and then a subsequent loss of motion. The condition is more common in women than men. Certainly, some people will recover fully, whether or not they have treatment, but it can take many months or even years for recovery. And some patients don't fully recover despite treatment. And it goes through a series of predictable stages where initially there's a lot of pain. People, understandably, because of the pain, don't move as much. And then the capsular contracture and the fact they're not moving as much causes some freezing. And then in the third stage, the joint is considered frozen. It stays that way for a period of time. And then again, in some individuals, it will just naturally start to thaw out and motion will be restored. So the onset may be related to a particular condition. It may just be insidious. One of the hallmark findings with this is loss of external rotation in neutral. And that's kind of a key exam finding that I'll demonstrate here in just a little bit. But there's also a loss of passive gliding of the humeral head, usually inferiorly, posteriorly, and anteriorly. And so those all need to be addressed through the manual therapy component. And in terms of how to treat this, how to categorize it, certainly you can try and deal with or approach it from the patient's level of irritability. If they have a high level of irritability, if they have a lot of pain and a lot of disability with that, they're not going to tolerate much in the way of aggressive manual therapy or exercise. And so appropriately, things would be kept relatively light on those fronts. On the other end of the extreme, if they have really low irritability, low levels of pain, low disability, but they're still having some motion loss, then the manual therapy and exercise can be more aggressive. And patient self-stretching is certainly an important component of success with treating adhesive capsulitis. There are different protocols available that describe programs of self-stretching. I think an important component of all those is to try and keep the stretching below the pain threshold. So I encourage patients to be persistent with the exercise program with their stretching, but not to push into pain, because that can actually cause more irritation of the synovium, more capsular fibrosis and contracture. So to summarize the treatment plan, and I'll go over in just a little bit here the exam and then manual therapy and exercise, but to summarize, self-management needs to be emphasized. The home program needs to be simple and concise, understandable for the patient. The exercise and manual therapy intensity and frequency need to be titrated, adjusted so that pain is kept to a minimum. And I found too, and I think other people have reported this as well, that using moist heat or having patients exercise in warm water helps to promote relaxation and improve motion. So I'll demonstrate some of the key exam features now.